suffer from sleep apnea in general. We're going to talk a little bit about a more unusual form of sleep apnea tonight, which is called central sleep apnea, and some newer therapies that are out there for this. So many of you may know sleep apnea, right? This is kind of the classic picture of sleep apnea. Somebody snoring, shaking the windows, so to speak. But sleep itself is very important to your health. And every day something new is coming out about how it affects different aspects of our lives, from fermentation to some links now. There's a sleep meeting going on right now. It links to dementia with lack of sleep, as well as cardiovascular diseases. But you personally are an expert on sleep because you know what it feels like when you feel poorly and you don't get a good night's sleep. So it doesn't take an expert to tell you what it means to feel badly when you get bad sleep. It looks like this, right? The next day you feel really tired, fatigued. It's tough to think straight. You may be forgetful. You may just feel like you're kind of living in a fog, a lack of stamina. And interestingly enough, bad sleep kind of gives more bad sleep. So if you have sleep apnea, you can also develop things like insomnia, restless leg syndrome. All of these things can occur in concert with poor sleep. So obstructive sleep apnea, which is on the right side of the page here, is due to airway obstruction. It's extremely common, especially in today's population. It occurs in over 10% of adults. And some of it is related to the obesity epidemic, so it continues to increase. Central sleep apnea is fundamentally a different disease. It's a disorder where the brain actually forgets, essentially, to tell the body to breathe. So patients just stop breathing, and it can be very profound. The average patient with moderate or severe central sleep apnea stops breathing about 27 seconds at a time. And then they can have many, many hundreds of episodes over the course of the night. So it's tied to a number of other different disorders, but it may not get picked up because oftentimes these patients don't snore. In fact, one of the more common complaints is actually that somebody gasps at night. So sometimes that gets interpreted as snoring because it wakes the other person up still, but oftentimes it's just, oh, I gasp at night. So let's take a look at what this means. So this is a cartoon showing how the brain normally sends signals down. And it sends the largest signal to the diaphragm. So if you take a big, deep breath, you can actually feel right above your abdomen this muscle contract, and that's called the diaphragm. And that movement of that muscle actually pulls air into the lungs. Now, it works in concert with muscles in your chest wall and in your neck, but really all that air is pulled in by the diaphragm. And in patients with central sleep apnea, they don't have that. Almost each minute of the night, they will stop breathing. And every time they stop breathing, that causes, I never realized how many big words this uses, but they have a stoppage of breathing as an apnea. And each apnea that they have causes a drop in oxygen or hypoxia. And then after that, the patient will start breathing very fast. And that causes an arousal. So awakening from sleep. You don't wake completely up, but you go to a lighter stage of sleep. And with that actually comes a surge in adrenaline, also known as norepinephrine. And that surge then can lead to lots of bad effects of sleep apnea. It can cause fast heart rates. It can cause low blood flow. It can cause inflammation. And overall, sadly enough, this leads back to cause more episodes because one of the triggers for central sleep apnea is high levels of norepinephrine, high levels of stress in the body, called an increase in sympathetic drive. And we see this increase in sympathetic drive in a lot of other common diseases. You see it in things like heart failure, really severe high blood pressure. You can see it in patients with a lot of coronary disease. Sometimes you'll see it with stroke. And increasingly, we're learning it's tied to other diseases that kind of go with the spectrum, like diabetes and kidney disease. So any of those can be the trigger for central sleep apnea. And once it starts, it continues to actually cause itself to keep going in a circle here to propagate this disorder. So actually, for a sleep diagram, when we look at it, it actually almost looks like music, because patients have episode after episode after episode all night long. And as I mentioned earlier, you can see that these increases in sympathetic activation have downward cycles. So one place that you can see the damage come in is in heart failure. So as these levels of stress hormones come in, you can actually see that over time cause strain on the heart. And over time, it is linked to worsening heart failure. But on the flip side, worsening heart failure can then actually be the trigger for central sleep apnea. Now, an important thing, and you all may have covered this in earlier recordings, is how do you know whether you have sleep apnea or how severe it is? And this is one example of a sleep study. And, I always encourage my patients as well as my family members to get your data. So this is a typical report from a sleep study. And you're going to know how severe your sleep apnea is by looking at the number of events of times that a patient stops breathing or has very shallow breathing, called a hypopnea, over the course of the night. So for this patient, they had 272 times, or 46 times per minute, that this occurred. So that puts them in the severe category. Now, whether they have obstructive or central apneas is determined by which one is more prevalent. It's just a numbers game here. And you can see here that this patient had 137 central apneas and only 12 obstructive apneas. And these are fairly straightforward to be able to tell on a normal sleep study that's done in a sleep center. And some home studies can do this, but not all home studies necessarily tell the difference. And and that's okay. And we can talk about, how it would get diagnosed otherwise afterwards as well. But here you can see this patient clearly has central sleep apnea. Now, the treatments for central sleep apnea, there have not been a lot of options. So for obstructive sleep apnea, another talk for another time, there's a lot of new and great therapies out there. But for central sleep apnea, traditionally CPAP has been used, but it wasn't really designed for that. It was designed for obstructive sleep apnea. It still tends to be first-line therapy for many patients. There is an advanced form of mask-based therapy called adaptive servoventilation that is appropriate for some patients with central sleep apnea. So if you have that, you may have been tried on that, but it's not indicated for patients with lower ejection fractions. So really, that's it. There are some medications that can help in typically milder forms of the disease. So this is the newest therapy that's specifically designed for central sleep apnea. And it's called the Remedy system. And the Remedy system is indicated for moderate, which is at least 15 events per hour, to severe central sleep apnea in adults. It only has two contraindications. One is we would not want any kind of infection going on at the time that the device was implanted. It is a fully implantable device, or right now it's not MRI tested, and I'm happy to answer questions on that as we get a little further on. This is what it looks like. It's really designed to look like a pacemaker or defibrillator. And in fact, that's where it's put in. It's typically placed by a cardiologist cardiac suite where other pacemakers and defibrillators are placed. And so it looks a lot like that if you've ever seen a picture. This is the device. It's typically put in on the right side of the chest. It goes underneath the skin through a small, usually 1 inch or less incision. And then the wires are actually placed through sort of an IV type apparatus through a vein. And the vein is designed, if you recall earlier, we talked about these nerves that go down to the diaphragm. It stimulates a single nerve. Typically, this one on the left, about 2/3 of patients have a wire placed on the left, and a third will have a wire placed on the right side to stimulate one of these phrenic nerves to move the diaphragm. And that's designed to then restore a normal breathing pattern in patients so that those stoppages of breathing don't occur. In many patients, we also place what's called a lead or a wire out another vein, and it's going to actually measure breathing. It's going to let the doctor be able to see the breathing over the course of the night with the device. And this is, and again, another cartoon, really letting that, you see that stimulation is going to come down. The diaphragm is going to contract and air is going to get pulled in so that you no longer have then a pause in breathing, as can happen with central sleep apnea. Now, what happens when this occurs? Well, sleep apnea events are prevented. So you can see here that out through 5 years now, there's a significant decrease in the number of events per hour. Specifically here in the orange are central apneas, periods where the patient's not breathing at all, but those almost go away and they stay gone for 5 years. And this is not a treatment for obstructive sleep apnea, and everyone has a few, so less than 5 are normal in adult patients. And you can see here that those don't really change. And then there's shallow breathing, and the shallow breathing gets better, and it's remained down over 5 years, but not quite as much as the overall central apneas. And again, I thought these are, sorry, it's not lit up very well, but these are the overall number of events per hour. And the time here is by year, 1, 2, 3, 4, and 5 through these boxes here. I don't know what happened to our bottom measures here, but you can see the AHI come down and stay down. Oxygen is the same way. The number of times that oxygen drops comes down and remains down. And obviously the central apneas, they come down and they remain close to 0. But what does that mean to a patient? Well, things that can be expected with the therapy is an improvement overall in daytime sleepiness. That's typically measured by a scale called the Epworth Sleepiness Scale. Improvement in overall quality of life. About 79% of patients had an improvement in their overall quality of life after 6 months of therapy, and 95% of the patients said they would do it again. But more importantly, we're going to want to hear from Mike, who can tell you what it's really meant to him. Now, this is an implantable device, and it's not going to be appropriate for all patients. So it's really important to discuss this therapy with your sleep physician and the cardiologist that would put them in. 97% of patients were successfully implanted, and 91% of patients were free from serious adverse events. So very safe, almost identical risk profile to a pacemaker. So what if you were considering getting the Remedy system, or maybe somebody that you know? Well, the first thing is you need a sleep study. So the sleep study is really going to determine right off the bat whether or not you would even be a candidate for the Remedy system, and not everyone is. About 1% of the population has central sleep apnea, so much less than obstructive sleep apnea. The implant itself is done, as I said, by a cardiologist. It's an outpatient procedure. Typically, patients have traditionally stayed overnight, but we're seeing more and more patients actually go home the same day. The device actually doesn't get turned on the day that it gets implanted. It needs a little bit to heal in and collect data. And the device itself is going to collect data, and then it will be activated about a month later in the office. And then over the next few months, there'll be several visits to have you come in and actually have the device specifically programmed for you and for your needs. I'm going to answer a couple of really common questions before I turn it over to Mike so you can hear from him, which I think will be the most important part of this presentation. So first of all, this is a device that comes on automatically. We hadn't really talked about that before, but when you go to bed at night, the therapy turns on and it automatically shuts off in the morning. How does it know when to do that? Well, the device itself basically has a clock in it, and it will come on at the pre-programmed time, and it'll shut off at the pre-programmed time. So when it is your nighttime, and that's set by per patient, and you're in your sleeping position, do you sleep on one or two pillows? Do you sleep in an incline or in a recliner? Hopefully not, but we have some patients that do that. It will only come on when you're at your sleeping angle and you're relatively quiet. So as long as you're shuffling around in bed, it's not going to come on. But when you lay down, you get ready, and it's your pre-programmed time that will automatically start out and deliver the dose that you need each night. And then when you finish up, if you get up at night, you need to go to the restroom, you stay out late dancing or partying, and now that we can all go to dinner, all you have to do is sit up and it will automatically stop. So what if you do consider this, that you do think that this is something you and your doctor would consider? What do you do next? Well, talk to your doctor. So certainly Valley Sleep Center knows about this now. And there are, and you can find, if you live far away, sometimes we do end up finding patients that are calling in that are not in the area, or you have a relative that lives far away. We do have a Find a Doctor actually on the website. If you don't know if you would be even a possible candidate, there's a survey on the website at respicardia.com that can help you determine if it might be a consideration for you. So with that, I'm actually going to stop sharing. And I'm going to turn this over to Mike Dingledine, who I feel very fortunate is with us today. He kind of went through this year with us and it's been quite a year, hasn't it, Mike? So
it has.
So he has a great story. So Mike, why don't you just talk about how many months now? You have almost a year and a half now since you went on this journey that was more than a pandemic.
Yeah, well, first of all, thank you for asking me to participate in this. I appreciate that. Hello to everyone. I started having a noticeable problem in early 2017. I knew that there was something going on prior to that, but I was a little bit hesitant to admit to anything or say anything to anybody. But in early 2017, it just got to the point where I knew something had to be done. And I was, to put it bluntly, I was just tired. I was tired all the time, worn out. I don't really know how to describe it other than saying that. And somebody can have a bad day and they can be tired at the end of the day. But when you have central sleep apnea, or what I didn't know I was having then, I was tired all the time, at day in and day out. And so I finally sat down and I talked to my wife about it and told her what was going on. She suggested that I go to my family doctor and tell them what was going on and see what suggestions they had. So I did that. I made an appointment. I went and saw them and told them how I was feeling and what was going on. And they suggested some routine blood work, but they also wanted to take it a step further and do a sleep study. So I agreed to do that, and I got scheduled for a sleep study. And after the sleep study, I met with the sleep physician. The sleep physician then told me that I was stopping breathing on an average of 52 times an hour. So that definitely put me in the severe category. which I didn't know much about sleep apnea at the time. And his suggestion was that we try a CPAP machine. So I got the CPAP machine, and I didn't want a full face mask. So I tried the nose pillow, which was the least obstructive, I thought. And over the course of 2.5 years, I tried a nose pillow, I tried a full mask, I tried I tried 3 different masks, and it seemed none of those were making any difference. It just couldn't adapt to the mask, and I didn't feel any better physically. I was still tired all the time. I was still waking up through the night. And in mid 2019, I was listening to a radio station, and they were talking about a device for sleep apnea. And many of you may have heard of this device. It was called Inspire. And so I Googled it and started looking at their website and getting information on that. And it sounded like something that might be of interest to me to do this, to help me physically. And so I got all the information I needed. My next visit to my sleep physician, I was telling him about it. He thought I'd be possibly a good candidate for Inspire, so he instructed his staff to forward all my sleep medical records to the physician that I had chosen. And I found on the Inspire website a Find a Doctor. I'm in Ohio. I found a doctor at Ohio State. I think highly of the facility there. And so I chose that doctor. They sent the information to him. And a few weeks later, I got a call. They set up an appointment for me. So it was October of 2019. I went to see a Dr. Chu at Ohio State. So he came in the room with an assistant, introduced himself, and pulled out a whiteboard, and he wrote on there, he had OMC. I didn't know what OMC stood for. And he wrote under the O, he wrote 0. Under the M, he wrote 4. And under the C, he said, I don't remember what the number was, but everything else was under the C. He said, so you have 0 obstructive. You have 4 mixed. You're all central. And okay, that's the first time I ever heard of central. And I must have had this look on my face. He said, you act like this is the first time you've ever heard this. I said, well, I thought sleep apnea was sleep apnea. I said, I didn't know there were multiple kinds. No, he said, there's obstructive and there's central, and you are all central. He said, so unfortunately, he said, I can't help you. He said, because Inspire is for obstructive sleep apnea. And he said, but he said, I do have some good news for you. He said, I have a colleague here at Ohio State that deals with central sleep apnea by the name of Dr. Augustini. And he said, if you would like, I'll instruct my assistant to forward your medical records to Dr. Augustini. And, you'll hear from them. So if something has to be done. So sure, I agreed to that. So they forwarded my records. I got a call from them. And it was early November, and I had my appointment. I met with Julie Meese, one of Dr. Augustini's assistants, and she told me about central sleep apnea and about the Remedy system and how they dealt with central sleep apnea. And so that's the first time I had heard of that. And we discussed it, and I said, okay, so what do I need to do if I want to proceed? Well, she said, I suggested another sleep study. She said, your sleep study is a few years old, and we would like to have a more recent study. So I agreed to do the study. And when the results of that study came back, my 52 had now progressed to 57 times an hour that I was stopping breathing. And so in the meantime, I had done a lot of research on Remedy. And she asked me what I thought of that and if I wanted to proceed. And I said, well, to me, this is kind of a no-brainer. I said, something has to be done, and yes, I want to proceed. So they took my medical information, submitted it for me to the insurance company, and a couple of weeks later, I got a phone call that said everything was approved. And by this time, that obviously time had passed, so they scheduled me for January 9th of 2020 for my implant. I went in that morning, had the implant, back in the car that afternoon and heading home. Obviously, the device was implanted, but not activated. But I was told that the device would be collecting data, how I was sleeping, what time I went to bed, whether I was sleeping on my left side, my right side, or on my back. And all that information would be used at the time of activation. So I went through the rehab period. They said it would be 4 to 6 weeks. In my particular case, it turned out to be 6 weeks due to a scheduling problem. I went back on February 24th of 2020 for the activation. They downloaded the data off the device, and we discussed how I was doing, what I was feeling, and what I thought needed to be. So they set it up for the left side, the right side, and the back for different sensations. And I went home that night to really not knowing what to expect, how it would feel. I mean, I know I did it in the lab, but now I'm going to be alone in bed wondering what's going to happen. So I talked to a patient ambassador that Respicardia had put me in touch with. And his suggestion was that he said, go to bed 20, 30 minutes before it's supposed to turn on, go to sleep and see what happens. Well, that's easy enough for you to say, but okay, that's what I'll try. As it turns out, I give that person credit because that's some of the best advice that I ever received. So I did that. I went to sleep about 20 minutes before it was supposed to turn on, which was 11 p.m. at night, and never felt it turn on. In fact, the first night I slept till after 7 o'clock the next morning. So the device had turned on and turned back off. And I thought, this is amazing that I was able to sleep all night. That has not been the case every night. A person of my age sometimes wakes up due to, need to use the restroom, or as you mentioned before, diabetes sometimes plays into this. I'm a diabetic. So if my sugar would drop to a certain level, I wake up so that I have to address that sugar low or whatever. And so there are occasions where I wake up, but for the most part, I sleep better. I've been back multiple times for different, I call them optimizations, okay, where they download the information, they look and see how it's working, whether it's working fine on your left side, but maybe not so good on your right side or on your back. We make some adjustments to the settings. We go home and we try it again. So I've been back several times. Each time I feel is a step forward. It's the sensations get stronger. Nothing disruptive though. When I say stronger, you take that with a grain of salt. Your body adjusts to it. I still don't feel it come on. If I wake up through the night and I lay back down and I start thinking about what I'm going to be doing that day or whatever, I may still be awake when it turns back on. If that which should become bothersome, which it hasn't, I can always roll over or sit up and it'll turn off again. And when it turns back on, it turns back on at its lowest setting. And when you go to sleep, then it kind of ramps up and gives a little bit stronger sensation, which I've been told then creates a fuller breath of air for you, which is beneficial to you. So, it's been what now 15 months since I've been activated. And it's a process that I would recommend to anyone that suffers from central sleep apnea. It's been a life changer for me. I credit that device for actually saving me, because I don't know what path I would have been 15 months by now if I hadn't done that, what kind of shape I would be in. My quality of life is better. I have more energy. I'm more active. I'm more pleasant. But I know where that's going. But it's been a good experience, and I would highly recommend it. And I'm thankful that I had persisted and found somebody that could give me back what I always hoped to get. So I appreciate you listening to my story. Thank you.
Thanks, Mike. It's always great to hear you. I noticed that you've worked in now from the last time we talked. Your wife's comments on on changes. Maybe I'll start out with, I have a couple of questions, and then I'd encourage you to go ahead and type in some questions into the chat, or into the Q&A, that we'll be happy to answer them. But a couple of common questions. Can you describe what it feels like?
What it feels like when it turns on, it is a little bit different in the fact that it's taking over, it's breathing for you, it's causing you to breathe. Okay, so if in fact in the lab setting, when they test out a new setting, they will have you hold your breath, then release your breath, and then they turn it on so that the next breath is generated by the device. Okay. Now, if you're sleeping, you might be in between that period where you're trying to breathe and it turns on and it's trying to breathe. So the first one may seem a little bit strange, but my advice, or what I've done in the past, is then just get in rhythm with that device, because that device, when they first turned it on, I know that we had two people from Respicardia there, along with Julie Meese from Dr. Augustini's office. And unbeknownst to me, when I was laying there, those three people were timing my breathing pattern. Okay. And they arrived at 14 breaths a minute. So it doesn't speed up your breathing. It doesn't slow down your breathing. However, having said that, it could. They could adjust it so that it breathes faster for you, or in fact slows it down. But I found that I've been on 14 since they turned it on. They've never made it go faster. They've never slowed it down. So 14 is my number. But it's not a disruptive feeling. It's hard to explain. To me, it's a reassuring feeling, knowing that I am not going to stop breathing because that device is activated. It's turned on for me. And in fact, as I said before, it used to come on at 11, turned off at 7. I started staying up a little bit later now, since I'm getting more sleep in that. So I tell them, okay, let's turn that back to 11:30. So now it doesn't turn on to 11:30, still turns off at 7 a.m. If I happen to get up earlier, it shuts off when I sit upright. So
it's a question that came in, Mike. What happens if you want to stay up and watch a movie late at night?
It does not turn on. I've never had it turn on when I've been upright or active, up and about or whatever. I usually don't stay up much later than that. There's been maybe 2 occasions in 15 months that I have stayed up later, but I know that it does not turn on until I get in my reclining, restful position, my sleep position, when I lay down and let's say become motionless, okay, for a period of, I don't know whether they time it in seconds or a minute. Once you lay in that position, then it recognizes that you've now laid down to go to sleep. It's past your time to turn on, so turn on, and it turns on. So it's pretty good. And one of your illustrations was a 2-pillow or like a reclining position. And I'll confess, I had about a vertigo back in early 2017, and I still cannot lie completely horizontal. So my device is adjusted so that I'm at a certain incline, because I have a adjustable bed. And so it's been adjusted for me. So when I get in that position or less, it turns on. If I'm higher than that, it does not turn on. in an upright position, but it does work in a reclining position or an elevated position.
That's great. The next question that I got I'm not sure if you've been able to travel much, but is a question about time zones, and maybe I'll take this one. If you're traveling for a single trip, then the device can actually be programmed to change on the day that you go from one time zone to another and when you come back. So it also does that for daylight savings time. So it'll automatically, on the right day, change over to the new schedule. If you're traveling a lot, and maybe we can see hope in the future that we'll get to travel again from different time zones. Sometimes what we'll do is spread out the window, and then you just know that when you lay down, there'll be a little delay, but then it'll come on. And so there are ways to program this for a variety of different issues. The hardest one we've had is we had somebody do a transatlantic cruise where you change an hour every night. And so that's exactly what that patient had, is they had a really broad window. Then when they laid down at night, we gave them a little bit longer to get to sleep before the therapy came on. So, we can really, the therapy can accommodate most lifestyles. This question I think is for you. Did it, the first night you said you slept really well, but have you ever had it keep you awake once you woke up?
No. Short answer, no. I do wake up at night sometimes, like I suggested a few instances where I may have. And if I lay down, I'm a thinker. So I might think about, okay, I got to do this today. I got to do that. I got to be here. I got to be there. I do whatever. And if you do that and you get into, you're thinking for 3 or 4 or 5 minutes or whatever, that device will have turned back on again. Okay. But when it does, now it's breathing for you. I mean, you know it. So, hey, it's time. If it becomes an issue for any person that has this, my only suggestion is that just sit up or roll over. It'll turn off. Then when you're ready, lay back down, go to sleep. It does not keep me awake because I sit there or lay there, and basically I get in rhythm with the breathing, sync with the breathing, however you want to say it. And the next thing you know, I might wake up and it's 4 hours later. And I went back to sleep, and so no, I don't have the sensations are not strong enough to ever awaken me. I've never woken up due to the fact that I felt a jolt, because it's really not a jolt. It's not a shock. It's not a jolt. It doesn't do that. When I'm asleep, it's just working. That's all I know.
Really interesting question has come in through the Q&A, which is about central sleep apnea that's associated specifically with altitude, but a great question on whether CSA can change over time. So there's a couple of different forms of central sleep apnea. So the one that's probably best known is that associated with heart failure. And in fact, for patients that have brand new heart failure, especially one that is associated with an injury like due to a virus or what we call postpartum cardiomyopathy, the central sleep apnea may still need to be treated, but oftentimes if the heart gets significantly better, the central sleep apnea actually can get better. So you want to make sure that the heart failure gets treated before you'd be implanted. So your doctor may try something non-invasive to get you through that period until it recovers. Altitude is a very different thing. So everyone can get a form of central sleep apnea called periodic breathing if you go high enough. So this is why as people climb Mount Everest, everyone needs oxygen by the time they get to the top. But some people, right, can be in Florida at the ocean and get central sleep apnea. Some people get it in Denver, and some people, have to be, up on the ski slopes before they have this periodic breathing. Everybody has a different threshold, especially if they're healthy, to develop this disorder. And sometimes physicians can recommend that you would move, if you're at a higher altitude, down to a lower altitude to see if that helps the disorder. Sometimes it does, and sometimes it doesn't. And so that is something that needs to be then rechecked at the lower altitude. If it gets rechecked, making certain that the sleep study that you do then at the lower altitude can tell the difference between central and obstructive sleep apnea is important. And if you meet with your sleep physician, they can give you those numbers, so taking a look at the report yourself can be helpful as well. So making certain that you take a look and ask the questions, right? Your physicians and your team are going to should be very open to having you, especially because that's called a complex sleep disorder, to asking a few more questions, because it's a more unusual disorder than either of the disorders by themselves. It is fairly common that people with central sleep apnea have at least a little airway obstruction, but some patients can have quite a bit of airway obstruction. And then those two disorders need to be treated. They each need to be treated. Sometimes they can be treated with the same treatment, but sometimes they can't. And so understanding that while they may occur together, they're two different disorders can really help as you think through what the right treatments are for you. That makes sense, Mike?
It did to me.
That's the first time I've been asked that. It's the first time I've been asked on a patient webinar, so that's great. All right. Well, I know we're getting close to time here. Let's see. Let me see if there's any other questions. One is there's a quick question about a pacemaker. So about half of the patients with the Remedy system have a pacemaker defibrillator. So it is made to work together with those devices. But it is important that you make sure your doctor knows that you have that both before the procedure, or if you were to get a pacemaker defibrillator after the Remedy system, so that the two get tested with each other. And then there's a question about CPAP. If you have a CPAP and it's working and everything looks good, then you don't necessarily have to change therapies. You can use the Remedy system with CPAP, and sometimes we have patients that have both central and obstructive that need a little bit of CPAP for their airway obstruction, which is it can be a very nice therapy to keep that airway open. So luckily not often, but it can happen. Any final thoughts, Mike, as we wind this up to tell people that might have questions?
You pretty well covered it all. I think we've talked about quite a few things. I would recommend to anybody, if you know that you have central sleep apnea, this is my personal thoughts, that a CPAP machine is not the answer for central sleep apnea. And I think that central is more detrimental than obstructive. I'm not, anybody that has obstructive, that's serious as well. I'm not downplaying that, but I feel that if I would have had both, I would have treated, I believe, the most detrimental to my health first. As it was, I didn't have that decision to make. I was told I was all central, so I only had one route that I felt I needed to go. But like you said, in the support group that we have, there are people that have Remedy and also use a CPAP machine to address the obstructive. We just had one person that is getting Remedy and also has obstructive, and their obstructive is at a lesser level, and they are getting one of those dental pieces or whatever. I'm not sure the exact name for those, but that doctor wants to go both ways. He wants to go remedy and with that to treat the obstructive. So there are alternatives for both. And the thing is, which one is the predominant one? If central is the predominant one, I think you go that route. So again, I thank you for having me on here. I learn something every time I listen to one of your presentations. I really do. I like to learn about what I have, and it helps me to deal with it. So thank you.
Well, thanks, Mike. It's always great to hear you and to work with you on these. And hopefully those of you on today learned a little something as well, maybe about a disorder you have or one you didn't know about. If you have questions, Valley Sleep Center seems like a great place to get some of your questions answered. If there's something specific about the therapy, you can also feel free to reach out at respicardia.com. And if there's something difficult, those all come to me. We have a great patient liaison as well that can put you in contact with other patients like Mike that have the disorder, and he's just been wonderful to talk to a lot of our patients. So I really appreciate it, Mike, for all the work that you do. Thank you so much. All right. Well, I think with that, I think we will wind it up this evening. All right. Thanks, everyone.
Good night.
Good night.